Perceive, process, perform. Do you need inspiration for your practice, or do you simply need to practice inspiration? With this series, we aim to do both. Give us 15 minutes and we'll give you practice inspiration.
Howdy, I'm Jeff Rouse. I'm a prosthodontist in San Antonio, Texas. In 2013, I introduced the Seattle Study Club to the idea of airway prosthodontics. And since then, a lot of you started actually screening your patients and started working with physicians to get diagnosis through polysomnography or a sleep study. I bet a bunch of you also have gone through those sleep studies with your patients and found out they don't have any problem, or they barely have enough of a problem and we really don't even want to do anything about it. Well, come to find out, your diagnosis is most of the time correct. It's the physician that we're having problems with. And the idea that ultra mild sleep apnea needs to be defined differently, and we need to be able to work with them differently. So let's remember the APNEA-HYPOPNEA index. The AHI is looking at the number of events per hour through the entire night. So during the recording session, the technician is simply counting apnea, apnea, hypopnea, apnea, and at the end of the night, they divide it by the amount of time you've been asleep. If the arithmetic average is between 5 and 15 events per hour, it's mild. Between 15 and 30, it's moderate, and 30 and above, it's severe. So where is the problem? Well, we define apnea, that's pretty simple. It's a 90% reduction in airflow, 10 seconds long. It can be obstructive in nature, meaning that your soft palate or your base of tongue falls into the airway. Or it can be more central or neurologic, meaning you're not receiving essentially a signal to take the next breath. So the classic way of looking at this is that we obstruct, then we desaturate, then we have an arousal response and we take a breath. The problem comes in for you and I that the patients that are apneic, those are low-hanging fruit. Those are the easy ones to find. What you and I are finding in our dental practices, the bruxers, the people with TMD issues, those patients have more minor airway events, and we call those hypopneas. Hypopneas, the definitions are all over the board. It ranged from 50% reduction in airflow to 30% reduction in airflow, and today most labs use 30% reduction in airflow as their standard. 10 seconds is the standard as well, but then it becomes wildly variable again. It can either be a 4% desaturation, a 3% desaturation, or a 3% desaturation plus and or an arousal. So think about it, 30% reduction in airflow, 10 seconds long, 4%, 3%, 3% or an arousal. Basically, finding more and more mild events. Our issue is that Medicare accepted the highest of those standards, obviously, so they don't have to pay as much. The 2012 American Academy of Sleep Medicine guidelines said we ought to go with the lesser amount because that's where we actually are finding a lot more disease. So it could simply be the definition that's giving you and I the trouble in working with our sleep physicians. Let's look at an example of that. This is a heart health community-based survey where over 6,000 people had sleep studies done. They read them one of three ways, 4% desat, 3% desat, or 3% in arousal. Using the Medicare standard, 4%, only about 50% of the patients were seen as being normal. But if you use the lower standard, the one that we need our physicians to use, the 3% or an arousal, only 17% of our patients would be seen as normal. How does that impact our patients? I'll give you one good example. This is a gentleman that came in to me and was desperate for a diagnosis. He happened to be a lawyer in the Air Force and he was missing grade because every time they wrote him up, they would say he's lazy, he's not focused, he's inefficient. And he kept saying, it's because I'm so tired during the day. He believed that for a lifetime he had been having sleep issues and breathing issues at night. And his history would indicate that. Unfortunately, when he started working with physicians and dentists, they started giving him an appliance, a piece of plastic at night, rather than actually looking at his sleep, because obviously splints solve everything. In 2004, he went in for a sleep study. They said it's negative, you don't have a problem. In 2008, he did it again. This time they said, you don't have a problem, but here, try Ambien. In 2013, he's in Qatar and he starts having anxiety attacks. In 2016, the stress was too much and he checked himself voluntarily into a hospital because of it. All they kept doing is giving him more and more medication rather than actually listening to him. He said, "I don't think I'm lazy and weak. I think I just can't sleep." So I sent him into a sleep laboratory that actually looked at both the standards. One of the standards was the Medicare standard, the 4% desaturation, but then they also accepted the 3% or an arousal standard. If you use the traditional standard, he would have had an apnea level of 4.2, which means the report back to him would say, "You are normal." But instead we use 3% in arousal, and those numbers would indicate he has a moderate level of apnea that needs to be taken care of. In fact, during REM sleep, where he deals with anxiety and depression and discomfort, he really had a problem. What was the conclusion of these sleep physicians? They said that the patient's obstructive events led to fragmented sleep and that it absolutely needed treated. He's been on CPAP ever since that sleep report, and at last indication, those sleep issues, those laziness issues have now gone. Now, the people that really suffer though are kids, because the standard is way too high for them. They do not desaturate the same way adults do, and they simply have too good of an oxygen reserve to meet these standards. So in this study, we're going to compare what the American Academy of Sleep Medicine standard is for children and what I think and Stanford thinks should be the standard for children. So the way the study goes is they had 200 children in the area that had gone through sleep studies, meaning there was a physician that saw an indication that they thought the child had a sleep problem and they wanted them to go in and get checked out. Many of these children had already been placed on medication for the reason that they were being sent in for the study. When the studies were graded, what they found is only essentially 19% of the children had what would be indicated as a breathing problem while they were asleep. The rest of them were told they are normal. The reaction of the physicians to a normal report put them on more medication. Stanford, instead of using the AASM standard, said, you know what, they're children, and we're finding impacts at a much lower level. So we're going to use a 20% reduction in airflow and an arousal or sympathetic activity as part of our indications. When they rescored the sleep studies according to their standard, they found 99% of the children actually had a sleep disturbed breathing problem that warranted treatment. Now, the other part of the study is they went in and treated a bunch of them. They got over 90 children to come in and be treated and started resolving some of those airway issues. And the interesting part of the story is, at the end of doing that, all but 5 children were off their medication. So there's a new vision out there. It's about mild sleep disturbed breathing issues. We know that as the airway begins to shut down, it doesn't require a complete closure for you to be harmed. In fact, that mild type of activity all night long, having to clear the airway and keep it open, that creates a chronic stress in the system. That releases norepinephrine and cortisol into the system at levels that create inflammation and damage throughout the body. We call that activity inspiratory flow limitation. Inspiratory flow limited breathing by the end of the night creates more work of breathing. And the work of breathing is what starts breaking the system down. It creates fatigue in premenopausal women. It can actually create or develop functional somatic syndromes. What are those? That would be fibromyalgia, chronic fatigue, irritable bowel, migraine and tension headaches, and TMJ-like symptoms. It can also lay the foundation for hypertension that is coming in the future. You simply don't wake up one day and say, I have apnea and by God, I've got hypertension today. It actually evolves over a period of time of poor breathing early on. Guy Monod, one of the world's most famous sleep physicians, tells us, as a child, if you have an anatomic limitation to be able to breathe correctly and you have these inspiratory flow limited breathing events over a lifetime, you will end up becoming the adult apneic patient. That's why we have to get involved earlier on these cases. We can't simply listen to the sleep study. We have to listen to what we know as dentists in the growth and development in these particular types of patients. This is a 6-year-old diagnosed with ADHD. He's a mouth breather. He's congested all of the time, although they've tested him multiple times and found he has no allergies. He's low on the growth curve. His tonsils are obstructive, so much so that he can't eat without gagging. From a dental perspective, he's bilateral crossbite. He's got an underbite, and he has a tongue thrust issue with an infantile swallowing pattern. We need to not wait on the physician, because when you send them out for the physician to actually begin therapy, they're going to involve a sleep laboratory. And that's where all the problems start happening, to be honest with you. He comes back with no apnea at all, which meant he got no treatment at all. Dentistry just needs to do dentistry. By expanding and moving this young man's arch out to where it's supposed to be, we gain more nasal volume. By including myofunctional therapists as part of the strategy, we can get his mouth closed and breathing through his nose. And many of the issues that have been isolated for this young man have a chance of going away or improving over time. Don't let him become the fat old man with apnea that we see too commonly. Thank y'all.